Good morning and welcome from all around the world to Structural Heart Live Cases, broadcasting directly from the Mount Sinai Hospital in New York City. My name is Pedro Moreno. I'll be your moderator today, and we love to hear from you. So please send us your questions, your comments directly to the website or on YouTube. Remember, you can view all the previous structural heart cases at www.ccclivecases.org. We have a great case today, so let me take you directly to the cath lab at the Mount Sinai Hospital for the live case.
All right. Good morning, all my team members here already here, and on left side, Dr. Keeney and Dr. Gilbert Tang behind, Dr. Rasail Khera, and we have two fellows here, and both all ready to present a totally different case. This is the first time we'll be doing it. That is TAVR-in-TAVR. We talk about TAVR in SAVR and all those, but question is now, and I'll present some data that knowing that more and more patients are getting TAVR procedure, so we have patients who are coming back. As you know, last year we don't have exact data, but about 85,000 TAVR were done in the United States. 85,000. It's almost 8,500, 8,000 plus, per month, and so many of them at younger age, and they do get some degeneration. So we'll present that data, and this is the case which we are going to show today. And welcome to all our viewers from the Mount Sinai Cath Lab. And let's start with our presentation. Okay, these are our all faculty involved. Actually, I didn't put Rasail Khera, he'll be there too. And Pedro, moderator, and our cardiac anesthesiologist, Morgan Montgomery. So key is all these cases are done with the conscious sedation. Last year, we did 453, and all of them were done with the trans-femoral approach, whether percutaneous or cut down. So about 7% cut down, but remaining all cases were done at Mount Sinai, trans-femoral. So this is the patient, 82-year-old, with worsening class 3 symptoms, have heart failure and recent admission for acute pulmonary edema. Patient does have various risk factors shown there, and patient had a 23 millimeter Sapien 3 valve in TAVR in 2018, and patient is end-stage renal disease, because that's where the issue comes down. And it's a patient of no, you want to comment on that, how this patient, I'm sure many of those patients who come back after TAVR have some gradient, little shortness of breath. We try to underplay it, but this patient really developed pulmonary edema when admitted, right?
Yeah. Amish, her initial presentation, though she was being followed regularly, I think what happened is she had an acute presentation. Now, was it related to because of her dialysis and under-dialyzed? But whatever, that was her first presentation. And then subsequently, we initially thought maybe there's progression of coronary artery disease. And we started all the investigation. And we then found out that there was, valve degeneration progressed.
And CAD was ruled out. Patient did have intervention in the RCA before, which are patent, other is non-obstructive, and then transcatheter, TAVR had a serial echo and now showed valve stenosis as well as some regurgitation with some mitral regurgitation also, but normal ejection fraction. So we will now ask Larakas, who is on the echo side, that has read it before with a severe aortic stenosis with a mild to moderate AI. So we better go with the live. This is the earlier one, or this is live now. Yeah, this is live.
Yes, good morning. Thank you, Dr. Sharma. On my right, I have our imaging fellow, structural imaging fellow, Dr. Lily Zhang. We took some transthoracic images just to measure better the gradients. This 5-chamber view, you can see normal LV-RV function, thickened aortic valve leaflets, and at least mild to moderate aortic regurgitation. These are the gradients, the LVOT. This is the of the aortic valve. The mean gradient is 24, as the previous Dr. Sharma showed. The mean gradient on the previous TTE was about 38. They obtained higher velocities, and the aortic valve area comes to 0.6 centimeters square, severe aortic stenosis, and actually the indexed area is 0.35. Normal LV and RV function, mild MR, mild TR. As you can see, the leaflets are very thickened. You can appreciate the aortic regurgitation. And you can see the turbulent flow through the degenerative leaflets and the aortic regurgitation. This again another view. One image is more than 1,000 words. As Dr. Zhang says, you can see the thickened, calcified, degenerative leaflets with turbulent outflow and the aortic regurgitation. And there is some pericardial effusion, small to moderate. We have to know and follow this after valve deployment. Thank you.
Very good.
So,
So good.
Stam,
Great. Yeah.
sorry, it says, Stam, do you see signs of chronic AI, or is this mostly recent acute type of AI?
As Dr. Sharma said, this patient was followed somewhere else. From all the echoes we have here in the last 6-7 months, the AI was present, so it's mild to moderate. So I assume that the patient did not have any AI after the TAVI was done 5 years ago. So this was
and the whole question is, it's not a PVL.
Yeah,
it is coming through the leaflet degeneration.
Exactly. It's not a PVL. This is a valvular aortic regurgitation.
Now, other question comes, maybe, there is very little written on this subject. What if you have only degeneration of the TAVR valve, and just do the balloon valvuloplasty and not worry about putting another valve, because putting another valve always remains a question. You'll do live. Yeah. So, Gilbert, what do you think about? Let's say if this patient would have no valvular regurgitation of the TAVR valve is only stenotic, little calcified. What about just doing a BAV?
I mean, the issue is that prosthetic leaflet is not like the native leaflets, Dr. Sharma. So there's risk of stroke, there's risk of acute AI. So, I mean, just like in surgical valve, we don't do that, right? For stenosis, we just go with the valve. So degeneration, we typically have to, either do surgical intervention or percutaneous intervention for the valve.
Yeah, very important point, because we didn't find anything in the literature, but I can tell you in the complete TAVR trial, which is for the Sapien valve, which they will have, and they will have a hemodynamic evaluation of those patients, 2 year and I think 5 year. And if there is a gradient more than 20, they are asking us, because we are part of the TAVR, the complete TAVR trial, which will start shortly, that if gradient is more than 20, then you do the balloon valvuloplasty. But this is just the concept in motion. Yeah. So it's a concept. But anyway, overall, this is basically the case is that anytime you have TAVR valve degeneration, does present as both stenosis as well as regurgitation. We can go to the slides now. So this is the aortic. You want to comment on it?
Yeah. So you can see this is a 23 Sapien 3 valve, but even tracing the frame in the outer diameter, it's a bit underexpanded. You can see that their mean diameter is less than 23, and the inflow and outflow. Next slide. If you look at the midframe, there's a lot of heavy calcium. So you can see it's actually even more underexpanded. We can see on fluoroscopy later on. But the sinuses are small. You can see STJ is large enough, and we'll show you the depth of the implant actually is quite favorable for redo TAVR. Next slide. And you can see again, there's some motion artifact here, but we'll show you again in the actual aortogram, which is more important. So you can see the most important thing, you don't want to obstruct the left main or the right coronary. And you can see that here there should be enough distance below, and in fact the valve actually, you see it here, is below the left main and the right, despite what the CT shows. So we always correlate between the two. Next,
and the heights are good. And actually, I'll show you the data also, that once you do a TAVR-in-TAVR, and there are actually cases now, and they brought patient back for angiogram, almost in 1/3 of them, you can't even engage. So maybe Anu has to devise a separate TAVR cathode app for the TAVR-in-TAVR. So 1/3 of 30%, you can't even engage the coronaries. So that's, of course, you have to worry about acute occlusion. But more importantly, that once you do a TAVR-in-TAVR, coronary engagement is even bigger trouble. Femoral access, I think, is straightforward versus any difficulty. Patient already have a PTA. The Sahil, you want to comment on this?
Yeah, I think this patient has a little bit of complex disease in the aortic bifurcation, and patient had a left CIA PTA done in the past. So we are only using the main access to deliver our equipment. There's valve-in-valve case, so we really don't need a side access at this point.
But is the access okay?
Well, there is, from an access standpoint, this should be transferred.
On the left
there's
side.
No issue.
Yeah, no, means the left side. Is there a PTA still holding on?
Yes,
or?
PTA is fantastic.
Okay.
Doing very well.
Okay. All right. So therefore, we put it together. This patient has STS risk mortality of 14.1 and evaluated by heart team, extreme STS risk, and so decided for TAVR-in-TAVR using 26 millimeter Evolut PRO plus valve and cerebral protection device. Did you use Sentinel?
We could not because patient has dialysis and had
so cerebral protection device was not suitable. Great anatomy. We, as a default, every case we try, and if not, we write the reason in the cath report why it was not done. And this particular case was not done. And of course, you need to do a little balloon dilatation, and it's a 26 millimeter fit in very nicely with all the parameters and so. So that's where we are now, and we are ready. Anu, you want to show now?
Yeah, you too.
Yeah.
Can we show the aortogram first?
Yeah,
This
show the aortogram.
Go to the angio. Yeah, right.
Yeah,
there.
so you can see, we always look at the aortogram because you can see clearly the left main and the right above the frame of the S3. So there's no issue with coronary obstruction, but it is a very calcified root and valve, and you can see the waist of the S3 is a little bit underexpanded. And so that may, and with the patient being on dialysis, may explain the early degeneration. So we'll actually, Dr. Keeney and Dr. Shan will discuss the case plan here, but that's all you see. So we always look at the aortogram as a final decision in terms of the risk.
But very unusual, coming back in 4 years. So we have some cases in first year, but they're always related to the thrombosis.
Yeah.
So they develop some kind of clot or immobility. Yeah.
But we noticed in the surgical literature, Dr. Sharma, that dialysis patient, even with surgical bioprosthesis, they fail earlier. Because of the metabolism and other underlying comorbidities. So I don't think TAVR valve will be any different necessarily because the same patient factors.
Okay.
So yeah, look at the aortogram. We have AR1. So routinely we like to use AR1 when we want to cross a bioprosthetic valve. So we have AR1 here ready to go, and let's see. Do we use our usual technique to cross, or do we use a pigtail?
Yeah, this is a little different situation. When we have a surgical valve, we always go with the AR1 or AR2. Usually AR1 is the narrow route.
Pigtail may be okay to cross.
And the other one could be that you just have a pigtail. That's what has been our usual, but we'll try here.
How did the T show, Stan?
You want us to?
One thing to take a look is making sure.
We don't need that. Yeah.
One thing we have to be careful because this open cell, you don't cross the cell into the
that's
left
why
ventricle.
I think we were okay. Could Floro save that?
You want to change the pigtail first and then do the hemodynamics? Yeah.
Yes.
That's good.
So from a regular TAVR, Dr. Sharma, what would you anticipate that you have to keep an eye on for potential issues?
Right, I mean, it's the same way. The one most important being the coronary obstruction, right? I mean, and then second remains for the heart block, need for permanent pacemaker. But I would say, particularly, original data have been that when you are TAVR in SAVR, you have less annulus rupture, and so because there is already frame there. So it's the two important issues there are coronary obstruction and heart block. But coronary obstruction to me is the most important. So Gilbert, tell us some cases of this kind will come in the future. You say, no, we cannot do a TAVR-in-TAVR because it will cause more coronary obstruction. Some of the surgical SAVR cases happen that way.
Correct.
So we could not do the TAVR because we knew that it's going to, unless you do various basilica and other procedures. So what will be the situation here?
So there's some early experience now on basilica balloon assisted, usually open up the leaflet with TAVR valve. But the thing is that with TAVR valve, you have to align the commissures to have the leaflets facing the coronary to be able to do basilica. So it's not going to be on every case. And we published the global experience on TAVR explant. So these patients had surgery because they cannot get redo TAVR. And the outcomes have been pretty poor in terms of the mortality and the stroke rate at 30 days and 1 year. So it's certainly a very high risk, more complex operation, I would say, for explant TAVR than first time or even redo SAVR.
In the bottom, we can show the hemodynamics also. Although gradient now, we always know when patients are lying comfortably, the gradient always goes down. In the cath lab, now it's about 25-30 millimeter gradient.
But this patient has mixed disease, right, Dr.
And
Sharma?
AI also.
And AI also. So it's like the surgical valve. You don't necessarily have a high gradient, but you can have a moderate, and that can actually, patient can be quite symptomatic with this mixed picture.
Which is this patient actually presented with pulmonary edema. So this is clearly, we know that they're both mixed, and that actually is also that when the TAVR degeneration occurs, it is combined. Same AI, it's not only one type, similar to what happened with the surgical valve.
I think, Dr. Sharma, one of the biggest predictors for future TAV-in-TAVR will be the depth of the initial TAV valve. I think that is going to be a big problem because a lot of us are aiming for very high valve deployments, 100 zeros, 95.5. But I think that's going to preclude a lot of patients from getting a future TAV-in-TAVR because of coronary reaccess.
Very important point, and this is actually will be part of my discussion, that once you need to be, when deploying the TAVR valve, you need to think about if patient comes back and has a lifespan of more than 10 years predicted, that what you are going to do. So those cases, as Sahil just
go
mentioned,
150.
yeah, that you want to do a little more down versus up. So what you're doing now, we are dilating with a 22 true balloon.
Wow, you see that? It's a little waste inside the valve.
Nicely expanded.
No, inside the valve, so that's where could
No,
be
that was the constriction was.
Pacer off.
off.
Yeah, constriction was actually, you saw that. We can show the clear flow of pre and post.
Pacer 80, please.
So it was, remember on the CT, we saw constriction. Same thing has been obliterated now with the balloon.
The valve, please.
You want to show your pre and earlier, where there was a little dent, minus? Oh, yeah,
No,
here.
we can't
See
see
that? Concavity on the
Where? No,
right
other
side. Yeah, right side.
Yeah.
And then go plus with the balloon.
And this is a 22
Balloon.
true balloon. It's
Yeah.
not even 23, so
Became
it's 22.
straight. Yeah. If you can just do a little quick fluoro, you'll see right there. So concavity disappeared there. So now gradient may have gone down, but AI might have increased, but that's okay. We need not to test. Our plan is patient has the original Sapien, and it fit in with a 26 millimeter
Looking inside
Evolut,
the valve.
and that is what we are planning here, 26 millimeter Evolut.
Inside.
Can you do a Sapien to Sapien? Yeah. So that actually have been, we could say, the same valve.
Inside
You have
the
a
valve.
self-expanding to self-expanding,
I can't
balloon
read the
expandable to balloon expandable,
leaflet.
and of course you can do a mix and match. Majority of the cases have been other. So you put a original balloon expandable, you put a self-expanding.
Okay.
You have original self-expanding, then you bring the balloon expandable when you do a TAVR-in-TAVR. Okay, so we are ready to.
Yep.
Gilbert, thoughts about
So where,
commissural alignment
how are
in
we
these
going
cases?
to position this valve?
Well, we want
alignment-wise?
to try to get commissural alignment as well
Okay,
because
good.
of the coronary access, as Dr. Sharma mentioned, Dr. Kinney mentioned.
Go.
But we also want
we
to make
go
sure we
lower
have
depth?
the hemodynamic of the Evolut valve here inside the Sapien. So I think we got to try to aim at the inflow to inflow, like this,
Go in
I
a
think.
little bit more.
And then,
I would want to go in.
And then because it's not going to embolize or migrate. 150, please. No higher, no deeper. Huh?
Yeah.
So we try to aim for the inflow to inflow. I think. You push.
Push?
Let it
No,
flower a
push the
little
wire a
bit.
little
will
bit.
be okay.
Push the wire.
Right?
No, I
Good,
think
good,
I
that's
want
it,
it.
that's
Now
it,
it's
that's
good.
it,
Now
that's
it's good.
Good.
Good. Okay.
80?
Nice.
Wait. Let's wait a little bit.
You want to do the cine?
Not yet. Yeah, I'm going to go in.
Actually, it covers the lower part of the Sapien frame,
Yeah, a little bit.
right?
It
does?
looks deep. It looks a little deep, I think.
I think I want it there.
No, but you're
No,
gonna
that's
have to,
okay.
you
Looks
lose the
all right.
hemodynamic feature. You
Yes,
really
you'll
want it
get it.
higher.
You want to remove the parallax?
No, we don't have the parallax, but we also want the
Remove
one
the
that
parallax, Gilbert.
Okay,
So,
so
Pedro, you see it, there is about
Absolutely.
half a
Here.
cell, so
Yeah,
like
cylinder,
2-3
yeah.
millimeter, but that I think is okay in my
Yeah,
opinion.
we need that.
Yeah.
Yeah.
the-
because you lose the supraannular,
Yep.
potentially supraannular benefit.
Okay,
Yeah.
let's do another cine.
Gilbert, I actually
It's good.
Looks good.
I like it.
because you're still going to be higher than the
Yeah.
original leaflets.
Okay, go pace.
All right, we might have to post
Okay.
it. Okay, 150. Wire back. It's neutral.
Yeah, I'm just.
It's not going to do anything.
yeah,
it's not
it's
going to
just
fly.
gonna-
It's not going to. Okay, good. Okay, 120.
Leave the wire.
Leave the wire. Leave it.
We have
We're
to
good
bring
hemo.
the hemodynamics,
With
yeah.
the hemo.
Okay.
So basically,
Okay.
the valve
All right,
actually
back up.
rarely embolized because you know the position.
we post?
Same thing when you do a.
We might have to.
And if we have to
22
post
true.
dilate, is it 23 millimeter or what do you want?
22
to do?
true. 22 true.
22.
Or
Let's just
23
post
true.
it.
23 true?
Yeah, if
Okay.
we want to do
You
it,
can do
please.
a
23
quick
true. 23
echo.
true.
Yeah, if we have to.
You want to see with echo?
Hemodynamics first.
You
I
can do
I
that.
probably would actually.
Yeah. Let's do a 23 true. Guys,
Let's
look for a
post it
23
anyway.
Yeah.
Yeah, let's do a 23 true. Because what happens is you want to expand it further. Now you have full protection with a double layer of stent material for any calcific causing annular rupture. right? I mean, little
Yeah.
safety net has been there.
I don't know if anybody is following what I'm talking.
Okay, put some color, please.
This
Yeah, give us 23. Go guys, get
Really
ready quick.
straighten it out
that
nicely.
is no, that's probably the leaflet of the Sapien.
Okay, like that.
Yes, the white line you see.
No,
yes.
okay. Stamp, comment on your echo.
Compress.
Yeah, just minimal PVL from this view, and some central,
So what
but the
I'm
catheter is through. So minimal PVL, good deployment.
That's a Sapien leaflet.
That's it. Valve, good position.
Good.
Leaflets are moving.
Yeah, you see the waist.
No
All right.
turbulent flow.
I want to go back to fluoro. Okay, when he's done. When he's done with echo.
Okay, go to fluoro now. Active fluoro, please.
Yeah.
Yeah, good.
No, not that.
Oh,
Yeah.
you mean the one you want to show that
I
point
wanted
here?
to show the point there.
Here.
Yeah.
Okay, this one. So when we went,
Here. Play that.
yeah, let it play. Pedro, are you able to appreciate just near where the
100%.
pacemaker wire is crossing the valve? You see like a white line, probably the
waist of
Sapien
the balloon.
leaflet.
The waist of the balloon, you
waist
can
of the
see and
balloon is
appreciate the
probably
Sapien
from the
leaflet.
Sapien leaflet. Yeah.
Yeah, the Sapien 3 leaflet, you can see it's quite thickened. You can see the
Thickened.
white
So
line.
That is
Yeah.
why we are going to post. We want to make sure that is well compressed before
Yeah,
we even
can
check
call
hemo.
it like incomplete expansion of the balloon because of the calcification.
And the calcified leaflet.
Yeah, calcified leaflet of the Sapien.
Yep.
Yeah, so this might be an interesting pathway to evaluate long-term outcomes
Yeah.
with this incomplete expansion with the balloon. Yeah.
This one, case 180.
But now,
So let's see. Should we go back to the same view? 1 second, SS.
No, this is okay.
No, this is
To
okay.
see that
yeah.
we are
This
expanding
fine.
that
No,
part.
but this is the
This is
better now.
Okay, good.
Good.
Okay, who has it? 180 now pacing.
Good.
Okay, going up.
Beautiful.
Yeah.
Oh, yeah. Leaflet
See,
is
I
high
think
bar.
we have compressed it.
Yeah. See that?
well, it look better.
Yeah.
So that leaflet shadow.
Okay, continue pacing. Okay, off. Okay, good. Now get the pigtail.
Good.
Yeah. Show that point again. That,
Yeah, but it's
now
also
no longer the shadow.
Yeah. It's also important, Dr. Sharma and Dr. Keeney pointed out, that after you put the second valve, it's very hard to expand the Sapien valve anymore. You can see that. So you want to do it beforehand, not afterwards.
Yeah.
That's a very important point, I think, for the audience.
Lesion preparation.
Exactly.
Yeah.
We need a big shock
Rota.
balloon.
Or a huge
Yeah.
rota to remove
Well,
the
they
calcium.
have worked on it.
Yep.
Concept of shockwave
In the MAC and
in
mitral,
the MAC
actually.
and
Yeah.
Yeah.
All right, so we got some hemo data coming
Here,
up.
Yes. Right. We're going to aortogram in the end.
Yeah, we have to, because we have to switch out
Let's connect
the
this.
catheter.
no gradient.
Yeah. You have to connect this. We will do aortogram in the end and flush both of them, groin and that.
So you see here, that's kind of a very typical
Shine.
position for the valve in
Beautiful.
valve. Okay.
Beautiful. Look at that.
Yeah, you can't really line up exactly,
Coronary.
at the bottom to bottom, because remember you're against a metallic frame. So, but this is, I think, a very nice result. It gives you room to post dilate, as you saw earlier. And commissural alignment, I think, looks very good.
Re-zero
You
both.
see the C-tap is pointing to the right side
I
of the
don't
screen.
like assist, you understand?
We'll show you in the aortogram.
Because of the contrast.
Coronaries
No,
are
but,
open.
no, it was not zero correctly. So
Yeah.
you can put it back there. Yeah. Yeah. Now it's okay. Good.
Good coronary flow.
Okay, great.
Both. Good.
Look at that.
Absolutely no gradient. Diastolic pressure good.
Yep.
So there's no increase, and then we are ready for the
Aortogram.
aortogram. Good.
Do a pull back and then we'll do an aortogram.
Yeah.
Okay. Yeah, yeah.
Laura?
Okay.
So I
Okay,
guess
Good. Come on.
one,
Yeah.
one
Good.
of
Are you
the
ready?
issues.
Yeah.
Yeah. Let's see the
Okay.
aortogram first.
Oh. Okay.
Okay. Now.
Good, go.
Let's try again.
Yep.
Nice.
Look at that.
Yes, sir. We saw no regurgitation. You start closing, yeah. And no gradient and no central or paravalvular leak has been confirmed by echo. And you have some question, Pedro?
Yeah, I think when we are doing
Negative.
valves, percutaneous valves in younger population, And we see these end-stage renal patients who have this dystrophic calcification with this
Nothing there.
hyperparathyroidism,
Come out.
so much increase. One of the objectives may be to try to go to renal transplant, after the TAVR, because that's the only way you may stop this cascade of early calcification and degeneration. Yeah.
Very good point. Very good point. So I think taking care of the renal issue in these cases are very, very important. And we have many cases now. I at least have 5, 6 of mine who got the renal transplant after the TAVR. So they did very well and they remained fine. But point is, everybody cannot get renal transplant because of the big waiting list and the limited resources for the renal transplant. So maybe they can find some kind of a xenotransplant. Now knowing for the heart going on with the pig, so will happen for there also. So with that note, while they are closing it, let's go back to our slide presentation. So very unusual topic, and I'm going to put things together. Our is basically recent publications about TAVR valve degeneration. So question is same, surgical valve and TAVR valve with a life expectancy dependence. As we know, the ACCHA guideline have come clearly that 65 is the cutoff. The 65 and below, surgical valve should be given a primary choice reason, because these people we expect going to live 20 years. And so clearly we know what are the advantages and disadvantages there are, taking care of the aortic dilatation and so. But of course the TAVR comes in because of the short hospitalization, and if they have comorbid conditions, it's a better procedure, which we all know. In between age group, like 65, 75, 70, we need to decide with a shared decision making with the patient preference and the values. Now, let's go through the timeline. More than 80 or 65 to 80. Less than 65, surgery. No question. Now you are 65 to 80, you put a surgical valve, which is below. 10 year, or you do a TAVR. Now 10 years later, you can put a TAVR again in both of them, TAVR-in-TAVR and TAVR-in-SAVR. The only question comes that what you do at the third point. And the third one is here. If you're 10 years, then you the TAVR-in-TAVR and SAVR? No. So I would say, and that is where maybe we ask comments by our experts here in my room here, that if we know the guy with the guy or girl at 65 years of age and going to live 20 plus years, and we know that they don't have COPD, they don't have a significant coronary artery disease, ejection fraction is normal, is it better to do the surgery first and then think about TAVR-in-SAVR and then TAVR-in-TAVR and SAVR? And of course, if the issue is that patient has more comorbid condition, we don't think going to live 20 years, probably 15 years. Doing a TAVR and then TAVR-in-TAVR will be the reasonable approach compared to on the top. If you're more than 80 years, patient should go for TAVR, and rarely if they have TAVR degeneration, and that's where the Gilbert's paper, the explant TAVR and use surgery in some cases, but otherwise TAVR is good enough for majority of these patients. Of course, some of them can live more than 100 plus years. You know, oldest patient we had done at Mount Sinai was 104 years, 11 months and 28 days. Put on the Mount Sinai website. And she then 4 months later attended her great granddaughter's wedding. So in this one, I really ask Gilbert and then Anu to comment that what is your overall picture on patients 65 and above, offering the TAVR as the initial strategy versus surgical valve as the initial strategy.
Yeah, I mean, I think to your point, the difficult patients are 65 to 70.
Yeah.
I mean, once above 70, 75, you know, they'll likely only need one reintervention because the life expectancy, even healthy patients, we have a life expectancy table to show that. And I think it really boiled down to the anatomy. I think if the TAVR first intervention, you can redo TAVR on the CT scan, and I think it's reasonable to say that that is a possibility based on current technology, and we can advise the patient. If it's really not feasible, but maybe surgical valve first is feasible for TAVR and SAVR, maybe that would be a good option for them. But no one likes to have surgery as the first time. We all know that. As long as they understand that we'll get a perfect result with the TAVR. I think that's the part most important.
Okay. Anu, your comment?
Yeah, I think concomitant coronary artery disease.
Yes.
That's what will be the deciding factor. So you are 65, bad CAD or moderate CAD, right? No CAD, maybe we go to the route of TAVR and TAVR and TAVR. But if they have CAD, maybe we should do first SAVR with bypass. Moderate CAD, what are we going to do? You know, 30, 50, 50, where we know we are not going to do anything, but
Right.
10 years down the road, they will have it, because our biggest challenge for interventionalists right now is coronary access. So I think just based on that, if you're 60, I'm just saying 68
Yeah.
has a mild to moderate disease, you know, we have to offer it to the patient, saying what, and then that's okay. That's the only, I think, will be a sticking point. Otherwise, should be okay for TAVR-in-TAVR-in-TAVR.
Okay.
Right?
And another
Yeah.
point will be, where do the Ross procedure will lie here in this?
Not
They
in this
are a
age
very
group,
young age.
but not in this age
Very
group.
young age.
Yeah.
Yeah.
So
less
I
than
think that's
65
yeah,
doesn't-
yeah, yeah. I
50.
mean, less than 65, 50 will be fine. But once you get to that age, it's probably not. Now, question will be that will there be some other treatment rather than just replacing it? Well, early, mild to moderate, more aggressive, some kind of medical treatment, high dose statin, although network. They're working on some
Shockwave.
radio,
Lithotripsy.
the lithotripsy or
Lithotripsies.
the radiation beam. So those kind of things, or maybe in the mild to moderate, bring the ultrasonic waves there. So many things are happening. But once you develop severe valvular stenosis, I think the intervention will be the way, whether it's a TAVR or with a surgical valve. Okay. So now, so we know that. I'm just going to quickly go through a few data that how do the TAVR valve compare with surgery. Everybody talks about TAVR valve, bad, bad, bad. Well, is it really bad? Let's put this way. Now, in the Sapien data of the partner 3 trial in the low risk patient, at 2 years, there were valve thrombosis of 2.6% versus 0.7 with surgery. So we understood that some cases with the balloon expandable valve will develop stent thrombosis, and these are the various, you saw it, that many of them found on the CAT scan, and gradient does increase in some patients once you develop more than 20 millimeter gradient, and so some valve thrombosis definitely has been reported, and reported a little more in the TAVR valve versus surgical valve. Compared to, and valve intervention is still a very less than 1% in both the groups. But same thing, if we take the core valve, and we have the data now 5 years of the CERT-AVI, of the intermediate STS risk, there's no difference in valve thrombosis, as you see. Gilbert, your comment on, and we also say no difference in endocarditis. The latest paper just came out also, that once you develop endocarditis, whether you take them surgery or medical therapy, aggressive antibiotic therapy is good enough. You don't have to take every patient with the endocarditis to surgery after TAVR. But more importantly, that the incidence of endocarditis after TAVR valve or surgical valve is identical in most of the studies. But my question here is, Gilbert, for you, that valve thrombosis we saw clearly in the partner, both partner 2 and partner 3, was a little more higher thrombosis in the TAVR cell balloon expandable valve compared to surgery, but we didn't see that in the CERT-AVI or the Evolut 2 year.
Yeah, I mean, there are different, substrate of patients, and also the, phenotype, and also the valve design a bit different. One's intraannular, one's supraannular. That might be something to do with that. The clinical sequelae of thrombosis, we don't know, right? We still don't have that answer to. That's really the million-dollar question. Because you anticoagulate, they resolve. Does that mean that you still affect the valve durability? We don't know the answer. So, this is still relatively low, but, it happens with surgical valves as well. Even though the rates are lower, I'm not sure what to make of it, other than maybe the valve design may have a difference.
Yeah, so clearly, as you pointed out, that once you have issue with the valve thrombosis, giving anticoagulation is better, but only thing is in the randomized trial, that by giving anticoagulation routinely who don't need it, create more trouble, and then we have to stop the trial of using Xarelto and so. So other thing also, hemodynamics. Look at the baseline gradient as well as the effective aortic orifice area. Much better with the TAVR versus surgery, and that has been consistently shown that you have a better orifice with the TAVR valve compared to surgical valve. Now, we actually have data up to 8 years now of the low risk group, which is the NOTION trial. These were all patients with the self-expanding. And you see here, mean gradient and effective orifice area in the red. Red is the orifice and the gradient is low compared to surgery. So that clearly has been shown. And then, of course, any structural valve deterioration, non-significant individual endpoints of the valve degeneration at 8 years, biprosthetic valve failure, identical between two. And of course, you have severe structural valve deterioration happen more with a surgical valve. This is a small study of 280 patients compared to TAVI, which was all were self-expanding valve. Remember, this is the only disadvantage was there was 33% pacemaker rate in the TAVI group. But key is it seems to be, now we have the largest data or the longest, I would say, long-term follow-up that how the TAVR valve compares against the surgical valve. We can say it may be same, definitely not inferior, except some issue of the valve thrombosis, particularly with the self-expanding valve. Okay. And so now question comes, you develop the TAVR. Now what happens? You do a repeat TAVR. And this is actually the data from our Medicare, and so that 30-day procedural outcome, mortality of 6, stroke 1.8, pacemaker 4.2. So clearly repeat TAVR procedures are going up. It's about 0.5% now, as you can see there. And of course, you can do repeat TAVR or you can do a TAVR explant. And the only problem is when you do the TAVR explant, you have a high mortality, 12.3% versus 6.2. But I'm sure repeat TAVR was the lower risk group compared to those who went for surgery, and 30-day MACE, as you can see here, overall event rate does occur, but much less in this group of patients. So there is actually a paper of the TAVR-in-TAVR, the systemic review with the meta-analysis of the 13 trials, and basically showed that some complications do occur in these cases, and the presentation is both stenosis as well as regurgitation. Rarely thrombosis, but there is a lot of data about TAVR-in-TAVR, and basically shown that you see the 48 patient study here, that 10 got the same valve, the balloon expandable, 11 got the same self-expanding valve, other had a mix and match. So like our particular case, I always believe, just like for the coronary, you have a one drug-eluting stent restenosis, we try to put a different variety. So same, I think, principle applies here. And I'll ask just your comment, Gilbert, on this issue. Should it be the same valve or should it be a different valve?
I think first we have to make sure there's no coronary obstruction risk. Yep. I think whatever second valve you put in. I think if there's not, then I think you want to see if you can optimize the hemodynamics. I think, most people, I would say, would probably use a different prosthesis because obviously there's some underlying issue that caused the first one to degenerate. Yeah. If it's paravalvular leak, then I think either option would be reasonable, but you also want enough radial force to reduce the PVL. I think that will be another consideration.
Anu, your point of view, particularly the coronary issue, will be another big issue here.
Yeah, I think a coronary access will be a big issue when you try to put a different kind of valve compared to leave the same. But I think like Gilbert mentioned, also it comes into equation is some paravalvular leak and the reason for degeneration. What is the reason for degeneration? So if the reason for degeneration is just stenosis combined, I don't know, nothing wrong in putting the same valve again, a newer valve. I mean, balloon into balloon expand to balloon expand, yeah.
They have mixed valve disease, so you have degeneration as well as patient prosthesis mismatch with an intraannular valve. So that's why it makes more sense to use a supraannular design in those cases.
Yeah, so mechanism, I think it's case by case.
Case by case, yeah. Initial valve size, initial annular size, coronary reaccess, and hemodynamics, and I think that should be guiding.
Yeah, so as you can see here, they have put it together. The TAVR-in-TAVR success rate high, with in-hospital mortality quite low. Stroke, actually there is a typo here, it's 0.6, both MI and stroke. And moderate AR is still in about 5% of cases. And so, of course, the issue comes here. More important is that once you have deployed the valve in a different strategy, that what is going to happen for subsequent coronary anatomy, coronary injection. So overall, they have quite, I would say receptive in the sense or encouraging results that you can put a TAVR-in-TAVR. Now, question is, this is again coronary angiography after TAVR in patients in TAVR-in-TAVR, and you can see here the big issue comes down because if you have a two exactly identical self-expanding valve, I think coronary anatomy angiographically is not a problem. But if you put the self-expanding valve inside there, it becomes real trouble. And of course, the little data of the accurate neo valve, and which they actually have shown that how it based dependent on how is the valve degenerate and how you are going to engage the coronary arteries based on particularly with the self-expanding versus balloon expandable, which always will remain. We know that always has been the issue in the past with the self-expanding, but commissural alignment, which Gilbert has advocated, and so definitely helps in re-engaging, and of course the CAT scan tells us a little better on that point of view. So key is that coronary angiography impairment, the female sex, supraannular design, STJ diameter and left coronary cannulation height, all those are adverse predictor of your coronary engagement. And they actually said the coronary angiography of a TAVR-in-TAVR might be unfeasible in almost 30% of cases. 30%. So therefore, we always have to think about when we are doing the TAVR-in-TAVR that what will happen to this patient for subsequent angiogram. So given the increasing use of TAVR in younger patients, new transcatheter heart valve should be designed to facilitate future coronary access in patients who may require redo TAVR. And I think that NU has already come up with a new app for this particular purpose, although it will be a little complex because you may not have much cases to evaluate. We don't have much data of the cases of TAVR-in-TAVR cases. I think in our here also we may have 5 or 7 patients.
Very few.
Single, in single digits and so. But this is a field which will continue. I just want to quickly sum it up that our surgical explantation of the transcatheter valve, which we already spoken about, the majority of them which happen within 1 year. Right? I mean, whatever happens when you do explant the TAVR valve, it happens within 1 year.
Yeah, it's a bit surprising, but I think this paper included the acute one. So it's mild migration or PVL, they need a second valve. They included that, you know, but in general, yeah, even the other paper you show, it's within, you know, I would say 5 to 6 months, which again, it's unusual as well. So it's certainly, I think, an issue.
Yep. And say clearly associated with higher mortality, 30-day, 1 year. So explantation is always a troublesome and so. And then this is the meta-analysis. I just wanted to complete this field of the TAVR in surgical valve and 30-day, 1 year mortality to a valve TAVR versus redo SAVR. Mortality point of view identical, stroke identical, major bleeding lower, the valve TAVR, and of course pacemaker implantation definitely higher on the valve and length of stay lower. The issue is the big one. That is that when you do the valve, the valve TAVR, that prosthesis mismatch, no matter how we try to decrease the gradient and post dilate, is much higher. And we know that some studies have shown almost 20%. You leave gradient of more than 20. So that's where the trouble is. While redo SAVR, we know, will take away this issue of the patient prosthesis mismatch. Gilbert, comment on that?
Yeah, no, I mean, remember, even with the TAVR valve, surgical, unless you fracture, you're not going to expand the frame anymore. And TAVR valve, you can't fracture. So you have pre-existing PPM in the whatever valve you put in, and you cannot fracture, you cannot expand the frame. The only way is to redo SAVR and put the same valve in, at least to reduce the PPM of that, because it's just going to get smaller and smaller.
Yep. So overall, so let's come up to the issue will remain that what you do when patient has a bioprosthetic valve dysfunction, and I think a lot of points which we have spoken, serial follow-up, and the mechanism remains valve degeneration besides having some cases of thrombosis and endocarditis and so. So let's come up with our 2 take-home messages that most of the studies have shown similar short and long-term valve durability of TAVR versus SAVR with better hemodynamics after TAVR in terms of lower mean gradient and better aortic valve orifice and slightly higher valve thrombosis in the TAVR valve by some studies. Second, with increasing adoption of TAVR procedure, especially in younger age, we'll encounter more cases of TAVR valve reintervention for valve degeneration presenting as either stenosis as well as insufficiency. TAVR-in-TAVR is a viable option for these patients. Surgical TAVR explantation in appropriate cases is feasible, but is associated with higher MACE rates. So 3 questions. Following our true statement regarding the TAVR versus SAVR valve durability, except similar long-term valve durability with the TAVR versus SAVR, similar need for reintervention between 2, similar rate of endocarditis with 2, and similar rate of valve thrombosis with TAVR versus SAVR. And answer clearly is D. It's not similar valve thrombosis. Some studies have definitely shown higher valve thrombosis with the TAVR versus SAVR. Then second, following statement is true. Regarding TAVR versus SAVR valve hemodynamic and long-term follow-up, it's not accept. True. Which statement is true? Similar aortic valve orifice, similar aortic valve gradient, significantly larger aortic valve area, and consistently higher valve thrombosis with TAVR versus surgery. So what is the true statement? Significantly larger aortic valve area after TAVR versus SAVR is the true statement. The last one, following are the viable options for management of TAVR valve degeneration except balloon aortic valvuloplasty, TAVR-in-TAVR procedure with similar original TAVR valve, TAVR-in-TAVR with a different original TAVR valve, and surgical explantation and surgery. And SAVR, clearly balloon aortic valvuloplasty makes sense, but has not been reported in the literature as a only sole treatment for the TAVR degeneration. With that note, we stop here, and we want to comment on your future app. You already, mind is machinery is app machinery going in.
Yeah, I mean, reaccess will be for the, would be hard. I mean, we can always make an, suggestion, the catheters, because we know we are done. Like yesterday, we had another case of prior, TAVR reaccess. That's always we can make. But I think what is interesting is TAVR-in-TAVR. If that's going to be coming up, there has to be a suggestion. App for that will be something that we will be planning.
That, 30%, they could not engage 30% in this one study.
Mm-hmm. Yeah.
After TAVR-in-TAVR. So definitely will require quite a bit of work. So Sahil, we want some comments from you on this today's case and topic.
No, I think, Dr. Sharma, this was a fantastic case. It really tells us about how much valve durability is important in these cases, especially if you see the TAVR explant registry, 25% of patients were low risk. So it really tells you that explant is not a straightforward procedure. It's higher mortality, higher stroke. There's a lot of neovascularization in these tall frames, the TAVR frames. And I think we should be very cognizant of deciding lifetime strategies for our patients. When they come to our office, we have to see what is the best strategy for them. And I think we really have to think about TAVR-in-TAVR and possibly TAVR-in-TAVR in low-risk patients is really not one of the most ideal strategies. So we really have to think about this for our patients now.
It's very important, and I'll conclude with that, and we'll ask Pedro from your side. So one of my patient, very educated dentist actually, 65 years of age, 64, 65. I said, you know what, all the good anatomy for the TAVR, I said, no CAD. I said, we'll do the TAVR, and you should go for surgery, but he had a consultation by our surgeon, Dr. Hamamsi also. But he said, I want to go for TAVR. I said, okay, but what will happen at the age of 75? He said, you put another TAVR. I said, okay. Now what happened with at 85? I said, you scientists, you'll figure it out by the time how to take care of the valve degeneration. I'm not worried about it. That's your job. All right, Pedro, we are done from our side. And yep.
I think just a comment, if the patient have extensive CAD and has a Sapien valve, maybe the homo valve will be appropriate instead of the hetero valve.
Yeah.
Just
Absolutely.
Yeah. Well, we don't have any questions. We just have a hi from Umesh Gully, who says hi. So hi, Umesh.
Good.
I was waiting for your question.
Yeah.
So it's beautiful. I think this is, again, one of the milestones of Dr. Sharma and Dr. Kinney's mind in teaching. Having a valve-in-valve in vivo with uneventful procedure is fantastic. So thank you so much for the cath lab. It's been amazing to see this exciting case. Remember, this case will be available for you at the ccclivecases.org. And also remember that we have our structural valve every other month on the second Tuesday. So the next one will be Tuesday, May 10 at 9 in the morning. Hope to see you there. Thank you so much.